Hello, everybody, and a really warm welcome to this session. For us, some of us quite early in the morning, but we see from the list that you're from all over the world. So a very warm welcome. And it is my pleasure to introduce this session to you. MSF, from the point of view of EMCC, MSF is one of our star provider organizations. And over the last 3 years, MSF have taken really steps and effort to embed the whole concept of accreditation within their coaching and mentoring program. And I've been very fortunate because I've been one of the early assessor within their international standard for mentoring and coaching program. They got the gold award 3 years ago, and then more recently they have renewed this accreditation and also got a gold award again. So a big congratulations to MSF and to the team of the hub, the mentoring and coaching hub. The other thing that has happened this year is that 2 of their programs on coaching has been also accredited as training providers. They've got what EMCC says EQA, the quality award. The mentoring program has already got accreditation, and also the first 17 plus individual people who are involved in coaching and mentoring have got their individual accreditation as well. So in the last 3 years, MSF has done so many things to embed and to bring in that aspect of professional standards within the program. So it is really great to see that. And I've worked with WIT, so I know WIT, but then several of you, if you're from MSF, would have been part of this process because we interviewed mentors and mentees as a part of the accreditation. So I'm going to hand over to the team, and you have a team of 4 delivering the session today. Sounds really interesting and is going to take you through the journey of the clinical programs, so a mentoring program, and talking about starting from the beginning right to evolution and evaluation as well, which sounds really that you're going through the whole process here. So yeah, I'll hand over to, is it to Wit I'm handing over? Yes, to it, and have a really nice session.
Thank you, Shandana, and thank you, Nicola. Thank you for the EMCC to invite us for this topic and for this session today. And also thank you everyone for joining us. For some of you, it's quite early in the morning. For others, it's a normal start of the day. We're here not to talk about the let's say the more general MSF mentoring and coaching program, because we've talked about that within EMCC for quite some time already, and we thought it would be interesting to dig into another topic that we're trying to develop, and that some of the people here have been working on for quite some time, and it's time to present that to you, as well as seek some advice, some learnings, some discussion on the clinical mentoring program that MSF has been working on developing in recent years, deploying it in a specific program, in a specific project as well in Kenya. And my colleagues who are here with me, so we have Terence and Ian from what we call the SAMU, which is the South African Medical Unit. They're based in Cape Town, where they have a decentralized division and part of that is focusing on learning for the field and increased quality for learning in the field. And then we also have Sylvie with us, and Sylvie is part of the team where I also belong to in Brussels within the HR department of MSF in Belgium. So very happy to welcome you here, and I'm going to pass on the word to Terence, who's going to present the clinical mentoring program. To you, Terence.
Okay, as Whit said, I am Terence. I'm from the Southern Africa Medical Unit. Well, Imagine that you are at a very busy rural and understaffed clinic somewhere in Africa, and there is a 10-year-old boy who's very sick and suffering from advanced HIV disease. There are only 3 qualified nurses, and they are not fully trained in providing care for patients with advanced HIV disease. These nurses cannot be moved to another area or town to be trained, because it literally means shutting down that very busy and understaffed clinic. This patient will survive if immediate care is provided, and in most cases it's just a single dose of medication. However, the next level of care is about 2 to 3 hours away, but the clinic does not have manpower, does not have transport, and does not have fuel to refer this patient. And this same scenario keeps repeating itself many times a day at this rural clinic. What would you do? Well, as MSF, we work in these low and middle income countries, and the traditional way of providing education is usually to parachute an expert to deliver a training and then fly out after a couple of days, hoping that the education provided brings about a change in the workplace. Well, as coaches and mentors yourself, you don't need any convincing that education endeavors that do not take learning into the workplace are unlikely to bear much fruit. Apart from our own experience of this not working, we are also motivated by the evidence in the education literature. And one of the guiding principles for us in MSF is the 70-20-10 model. It is more of a business model than one specifically researched in the context of education for health professions. However, it does promote similar concepts of workplace-based learning. And this model actually tells us that for effective learning to actually take place, 70% of what we learn it from experience and practice. 20% we actually learn it from other people. And interestingly, only 10% we learn it from formal classroom and training. Now, in 2014, Van der Vleuten and his colleague, they did a literature review looking for the real evidence for effective education, and they published this interesting, important article. What will happen to education if we take education evidence seriously? Now, to illustrate the directions that people might take to find better educational strategies, he pointed out to 6 areas of educational evidence. And we believe that this article actually speaks to the heart of what we are trying to achieve with our clinical mentoring program. One of the strategies that we have developed is to try and implement these principles that we have talked about to bring learning to a workplace by adding to the classroom hands-on support in the trainees' consulting rooms, drawing on mentoring principle. In fact, one person actually summed this up as teaching in a mentoring kind of way, because it draws on almost all of the mentoring principles. We call it mentoring, but because it is not identical to the type of mentoring that this forum usually engages in, we make the clear distinction by calling it clinical mentoring. And I'll provide a bit of more information on that a little bit later. But before I do that, it is important to note that we did not invent this educational approach. We first described it in 2005 in an effort to reduce morbidity and mortality associated with HIV. The objective in 2005 was to scale up HIV care and antiretroviral therapy availability, particularly in remote settings, by training nurses and other healthcare providers while they are at their workplace without even interrupting their usual services. Now, following these recommendations, MSF developed a pilot clinical program in 2011 for the same purposes. And we developed this program in Khayelitsha, which is a large poor suburb in Cape Town, South Africa. And this is what was called nurse-initiated and managed art. Eventually, the local provincial government, they created its own manual for clinical mentoring to be standardized across the whole province, following the successes that they noted in Khayelitsha, Cape Town. And the division of MSF that I work in, the Southern Africa Medical Unit, with our training reach into Africa, we have expanded the program across our projects in Africa. As you can see on the map there, we have expanded it to Eshowe, South Africa, Gutu and Mutare, Zimbabwe, Nsanje, Malawi, Beira, Mozambique, DRC, and Guinea. We are not the only people doing this in MSF. In fact, another division of MSF with whom we have close collaboration, the MSF Academy for Healthcare, is also rolling out this program of clinical mentoring, but specifically for hospital-based nurses. Now, as we develop these mentoring programs, there were inevitable challenges, often due to lack of human resources. So we struggled to find a suitable way really to roll out this program properly and later on evaluate its own effectiveness. However, eventually, we had the ideal opportunity to do so in 2017. We launched a full-scale clinical mentoring program in Embu, Kenya, but this time it was beyond HIV to support decentralized care of asthma, hypertension, diabetes mellitus, and epilepsy. And this is what we call non-communicable diseases. Primary healthcare staff with very little experience in managing these conditions, they needed to be educated. And we took this opportunity to recommend clinical mentoring as the learning implementation strategy. Now, here's just an overview of the program of how it all works, and it's just a summarized version of it. So ideally, what we do is that the critical first step is to do a needs analysis. And next, we structure a curriculum which is based on what the trainees should be able to do at the end of the program. The length of the curriculum is actually determined by the needs themselves. It can be 4 to 12 weeks long or subdivided into modules. In the meantime, we actually also select mentors with excellent technical skills. The mentors are given a training in communication skills and teaching skills. Then the specific learning objectives of the mentoring program are then used to develop training material for classroom teaching sessions and workplace training, that is side-by-side mentoring, case studies, and file reviews. And then in the fourth step, intensive mentoring officially begins, as marked by an opening event. Then weekly objectives are met by means of classroom training, followed by workplace training. And when the curriculum is done, there will be a closing event where mentees are awarded certificates. We have also developed several tools to document individual and programmatic data, and the results are then shared with all the partners that we would have worked with. Then the way forward, after what we call a first cycle, it depends on the learning and operational achievements, as well as strategic choices. It can include several possibilities, such as geographic expansion, or a repeat intensive mentoring, or even a mentoring phase. So that's just the summary of the program. Now, going back to Embu, what then happened is that the head office agreed to fund a full-scale evaluation of the intervention starting in 2020. This was done by an external evaluator, Dr. Paul Stokes from the University of Sheffield, UK. And this is the first time when one of our mentoring programs was evaluated in this comprehensive manner. And his experience is more in the realm of mentoring in the business world, but nonetheless, he did a very comprehensive and helpful evaluation. The objectives of the overall objective of the evaluation was to assess the appropriateness and effectiveness of the clinical mentoring framework as a mechanism for developing the medical competencies of the healthcare staff in Embu County in Kenya. And 3 specific objectives were actually identified, were to assess the extent to which this approach being used in Embu, whether it was sufficiently adapted to the local context, and also to examine the extent to which the mentees' medical competencies have improved. And also, lastly, to explore if there were any possible improvements that needed to be done. In terms of his conclusions, the evaluator concluded that the clinical mentoring program that was running in Embu was actually an effective learning and teaching model that is adding to the Ministry of Health staff capacity to deal with the non-communicable diseases in that area. And there is also sufficient evidence to show that the model is well adapted to the rural African context, and it is not a Eurocentric model. And this program has actually demonstrated that it has improved the trainees' medical competence. But one thing which was really noted was that it really needed enough preparation in terms of preparing the teaching materials and also the assessment of the mentees or the trainees' progress. But perhaps the most important outcome of the program was that the impact that it had to the Kenyan authorities. Their national program managers managing the non-communicable diseases were so impressed with the level of learning achieved that they decided to roll out this program as a vehicle for educating their staff in non-communicable diseases across the whole country. There are a couple of challenges that we have noted along the way for this program to actually work. In fact, it needs so much resources. It requires resources in terms of finances and in terms of human resources itself. And we need buy-in and serious commitment of managers. If it is not there, then the program will just fade away. And also, one thing that we have noticed is that it also needs a positive culture of learning wherever you are going. The trainees themselves, they must acknowledge that they have a knowledge gap and they are also willing to undergo this program. Another thing that is also needed for this program, for it to be successful, is that we need someone to be actively managing the clinical mentors that will be on the field also. But in summary, what I would like to say is that we are teaching in a mentoring kind of way. We bring structured learning to the workplace by providing classroom training, hands-on support to the mentees, whilst at the same time we'll be drawing on mentoring principles. And the objective is largely to develop competencies of the healthcare providers in rural settings without interrupting their usual services. Now, remember the scenario of the 10-year-old boy that we mentioned at the outset. By doing clinical mentoring, we are assured that we will save his life and many other patients also. So what is the way forward? We believe that we have developed and we are continuing to develop a model for effectively moving teaching and the learning process to the workplace, where the educational evidence is clearly showing that it needs to go. We're a bit behind in terms of researching the literature to see what is out there regarding the application of mentoring principles in this way, but we are actually in the progress of doing this. And we are not aware of others that are running this type of program. And if we find that there is not much out there, then our plan is to put this comprehensive evaluation to write up our program and then publish a research article on clinical mentoring so that we can start the conversation in the literature. Our big challenge is to scale up the program within MSF itself, and in particular to find ways to adapt it to varied human resources that we encounter in our projects across low and middle income countries. Now, it is actually wonderful that we have had this opportunity to be able to put this out there, especially into this forum, and also to hear your thoughts and ideas and suggestions. So for this purpose, we are going to go into breakout rooms at the end of the presentation. You will be able to ask questions, challenges, and even make suggestions. And in each room, we have a facilitator who's actually a colleague of mine with experience with this program. And they will not only answer your questions, but also they will be able to gather ideas and then all feedback in plenary. So in the breakout rooms, what we would like to do is to, if you have any further questions, and then we'll answer them. And also either from your experience or reading of the literature, have you encountered this type of clinical mentoring elsewhere, be it in rural, urban, or developed countries, or even in the literature? We would welcome suggestions on how we could scale up this, whilst at the same time appreciating the wide variety of contexts that we are actually trying to roll out this program in.
Yeah, I mean, I see that there's certainly, I mean, it's interesting just seeing some of the comments here, the discussion about adult learning approaches, relatively new and highly impactful. I'd actually be interested to know where did that come from, Suzanne? So where did that discussion go, where you're saying adult learning approaches are relatively new and highly impactful? How are you seeing that in application to the clinical mentoring program that we're doing? Where did that discussion go?
Hi, yeah, it was kind of a pondering, a question around that this form of learning has been around for quite a while, but relatively new within this space. So we were just wondering how, talking around that, and we were saying that actually it's very new, even though we're familiar with it, if we're in the learning space, but that actually a lot of organizations are still catching up around, and that the mindset shift from traditional education and learning versus modern learning and adult learning. So it was just a whole conversation. It was really interesting, actually, a whole conversation around that. And that it's, if we are in the learning space, which most of us were in our group, we were talking about we are the ones kind of promoting this and helping it to advance. Right, right. I mean, it is very interesting that this whole adult learning principles of the autonomy of the individual, not just throwing stuff at them, giving people opportunity to engage. Social learning theory, isn't it about just you creating opportunity for people to share their experiences and to learn together and to learn with others. I mean, one of the things that was very interesting that has come out that I've only just heard about in the last week, and I'm still planning to speak to the superb manager in the Embu project, is she said that as a result of this mentoring program running there, what's happened is actually a culture of learning has developed within the project,
which to me is just massively inspiring, because I think that's one of the biggest challenges we have, is creating a culture of learning, as you're referring to, Suzanne, just shifting the whole ethos into a culture of learning in an organization. And it seems like this clinical mentoring has actually done that specifically on the project. I actually sent an email yesterday to say, please, can we talk? Because I want to know how this has actually played out. But it's, it's very interesting. Just this is such an interesting crucible where so many things have happened. Anyone want to just add into that discussion before we pick up on something else?
Ian, just maybe interestingly from our group was the question, why only now is clinical mentoring or this type of adult learning becoming a point in MSF as a global medical organization, attentive to quality medical care and making sure that people actually do good to their patients? Why is it only now that it's become so formal, becoming so interesting?
Well, I'd have to give a sort of very gracious answer to that one. I can see some of my MSF colleagues smiling and saying, "How am I going to answer this one?" I think that one of the elements is that MSF just has this. I mean, their primary commitment is flying out into these crisis zones and delivering effective healthcare in where it's just drama and catastrophe, and MSF is there and they're building hospitals and doing whatever they're doing. And so even though education is spoken of as a priority, I think to look at the evidence base of how education really happens needs an enormous push. And as I'm often saying to my colleagues in learning and development, turning this in MSF, and I don't think we're alone in a large organization, is like turning a large battleship. It's not just a little rubber dinghy where you just swing it and it all changes overnight. And I think it's initiatives like this where we actually invest in something heavily and say, let's do this really properly. Let's throw lots of evidence at it. And interesting, I see Alan's on this call. That I remember visiting Alan 5 years ago, sitting in his office in Oslo, and he said to me, Ian, one of the things you must do is you must evaluate this, because you must do a proper evaluation, because when you have a proper evaluation, then you've got some data to actually show that it actually makes a difference. And I mean, this is now, I stepped right out of it and other people took over and did all sorts of amazing things. And now here we are in a position where I'm delighted to be stepping back into it again, because here we've got something that is a strong statement that the Kenya actually says, hey, this works so well, we want to roll this out nationally for teaching about NCDs. So we've suddenly got a strong evidence base that we now are throwing in. And now MSF is, and I mean, the Academy is doing their own stuff. So one of our other divisions where they're starting to show evidence that it really makes a difference. And I suppose it's just the evidence base that is starting to become apparent. And it's starting to make people sit up and listen and say, hey, this has got potential. I don't know if my other MSF colleagues would like to comment on that as well, because maybe higher up the organization, maybe you have a bit more insight than I do.
More or less the same way I answered Ian. So
okay.
I'm just going to complement. It's more visible, so that triggers more attention and more opportunities for discussions. But it's been around for almost 15 years. We've been doing clinical mentoring with success since 2006 or 7, I think, minimum in Zimbabwe. But yeah, just the visibility does help.
Yeah. I see there's a comment here from Luca saying, interesting to know who mentors and mentees are. I think that's very interesting to hear where that discussion went. Luca, would you like to speak to that? There you are.
Yes, I just reproposed the question. I asked simply who are the mentors and the mentees and how were they selected.
And what sort of answers did you get? Because I mean, that was in one group. I think it might be interesting for others to just hear what you guys came up with.
I can't ask it to Sylvie to answer again for the entire group.
Yeah, I saw another mention about recruitment and stuff. So about the mentors, they were specifically recruited also looking for specific, well, those that interest in, I guess, teaching others. So that was a very helpful streak already before we got around in, well, getting them on the learning path to become even better mentors. The mentees themselves were not so much selected, although they were required to show interest in the program to start with. So the people who did the initial first cycle of mentoring were the ones in the health centers we had identified who were the most interested, but they were not that well, they were not really selected, and hence there was a few people who dropped out in the very beginning for various reasons that were not really related to the program themselves. So that was also an interesting thing, actually, trying to get around identifying things that could motivate people and not being too selective, otherwise it can't be replicated so well. I don't know if that enlightens a little bit.
So I see, thanks, Sylvie. I see that Navneet, you've mentioned something here, wondering what if mentors would come from different walks of life or other parts of the world. Could you maybe just expand a little bit on that and where your discussion went with that comment?
Right. So that's an afterthought, actually. Once I was through with my discussion with the group. So, this thought came from the information that was shared that mentors were selected, and there was a requirement that mentors has to be a peer to the mentees. And based on one of the experience where, when I got involved in mentoring and coaching for the first time, I come from a very different background compared to people whom I was mentoring. And it was sort of very little difficult in the beginning, like, where I come from the conditioning that I have, the thought process that I've gone through and the experience I have, and the mentee come from a different background. But eventually it turned out that sharing each other's experiences and building over it helped the communication and, and the perspective that we both learned during the journey.
That's interesting. I think
so
maybe carry on.
My question, thanks, Dan. My question was, what if we have people not just from the peer group, but maybe at times from people who are outside the peer group, or maybe somebody from maybe a similar area, but somebody who, from a different part of the world?
Terence, I'd be interested to hear your comment on that, because you've been closely involved with the mentoring project in Embu, maybe a little bit more, not to mention a variety of other projects sort of scattered around Africa. My sense is that it's perhaps a little bit different with clinical mentoring, but what would your observation be about just perhaps the differences between mentors and mentees in terms of their backgrounds and the impact on the project, on the mentoring process?
Okay. Yes, so I think I would like to say that it might have an impact in terms of the different. Sorry, I didn't quite get the question really, or what he was. Could you please just repeat your question, and then I'll try to see how I can answer it.
Sure, Terence. So my question is the context is that we usually hire mentors, and one of the requirement is that mentors have to be the peer or from the peer group of the mentee. And my question is, what if we have mentors from outside the peer group? That's my first question. Will it help bring different perspective and some other thought process, a different approach to what we are trying to achieve? And I go without saying, I'm not an expert on clinical mentoring, and I would love to stand corrected on that. Thank you.
Okay, thank you. I got your question now. So one of the mentoring principles that we actually draw on is that the mentees and the mentors, it should be a non-hierarchical relationship, saying that the mentor should not be the boss of the mentee, because there's going to be it is going to impact how this relationship is going to evolve. So what we try to have is to have mentors who have a good technical skills. So as long as the mentor has good technical skills and is experienced in the area more than the mentee, then we can say that the relationship can actually work. So you can draw them from wherever, but as long as they are more experienced in the area, because we want them to be able to then transfer this knowledge to the mentees.
Thank you, Lawrence.
I'd like to pick up on something different here, which I think is it's a really important question and points to a real need. Deborah, you said what support or opportunities are given to mentors for supervision or reflective practice. So, I mean, this really speaks to the mentoring of the mentors in a way. Because I see given to the mentors, not the mentees. Sylvie, I wonder if you'd like to answer that, and maybe even Sarah, you might have some comment, but you might just need to introduce yourself before you do. Sylvie, let's put that one over to you, because you were certainly involved for 2 full years there.
So, yeah, I can speak to our experience in Embu, and from the very beginning, after the initial training, we really tried to foster self-reflection, reflective practices. Mm-hmm. So we did provide, well, first it was embedded within all the trainings and communications we were doing. And we provided canvases to promote the self-reflection, or frame that self-reflection along the lines of the different skill sets that our mentors probably needed to have. Mm-hmm. And the thing is, I think there was, well, in our group, we also discussed a little bit about community of practice. And all these mentors were new to the mentoring and kind of left on their own after Ian and I left after the first training. What the other thing we really tried to have them do was peer exchanges within themselves, within that team, no matter what kind of mentor they were, as in status-wide. Doesn't matter what you mentor on, the importance is the mentoring skills and exchanging on, well, your successes and challenges you're facing in, well, I don't know, establishing a rapport with your mentee or dealing with an absentee or that kind of stuff. So those peer exchanges, team meetings were happening, and I'm guessing still happening, once a week. But unfortunately, beyond really the Embu team, we never got around to creating a wider community of practice with all our different kind of mentors from different countries. That's actually in the works, right, Sarah?
Sarah, I think it might be helpful. I mean, so Sarah is involved with another division of MSF and running mentoring programs within hospitals for hospital-based nurses. Mm-hmm. And I'd be interested to hear from you, Sarah, if you'd like to speak to that as well. What are you doing with your mentors in terms of that sort of supervision or effective practice?
Sure, but so basically it depends a bit the countries and the strategies that we have in the country. But in Sierra Leone and in South Sudan, they are a team of mentors. So basically they are deployed in the field, and there will be 2 or 3 mentors working in the same project. So there is a lot of interaction going among them, a bit kind of intervision, or as Sylvie was explaining, team meeting where they will share challenges that they have. And also on top of that, they have a senior clinical mentor who is really an experienced clinical mentor that's also supporting them and also participating in those meetings. And there is the pedagogical manager who is really the top person also gathering also all the experience. And in terms of sharing experience between countries, so there is a kind of pedagogical manager community of practice that meet every 2 weeks, and they actually share what are the issues faced by their mentors in the field to actually see with others how do they do it in other countries. So that's a bit the way. When I was in Malawi managing the project there, we also had a very big mentoring program for HIV and TB. And there was a team of 4 mentors. And so every week they were having a team meeting, like Sylvie said, where they were sharing also all these issues as well. So I think this is how they learn, really.
Nicola, I'm just aware of time going by. How are we doing for time?
We've got another 10 minutes left.
Okay.
And I have
I'd like to, Deborah, I'd like to pick up on your comment, because I think you may be touching here. You've spoken and said some of the adult learning approaches which use reflective loops would seem relevant. I'm very interested, because one of the challenges that we're having is, if we look at the mentoring program at the moment, as we've said, and as you've probably gathered, this is very resource intensive. You know, you've got a mentor looking after, usually at most they have 5 mentees. So they will go, a mentor will then go to one mentee on Monday, another one on Tuesday, another one Wednesday, and then the next week you do the same again. And so you end up with probably 5 mentees that you're looking after. But one of the things we are trying to say is, how can you do this in a more poorly resourced setting where you've got fewer competent mentors? And we're trying to explore what are the different ways of workplace-based learning where you don't necessarily have to have this high intensity sitting with someone all day. So I'm interested to hear reflective loops, what you're referring to there, but with that, you know, is it perhaps one of the avenues that we need to go down in terms of how to do this in a slightly less resource intensive way?
Can you hear me?
Yes, clearly.
Yes, yeah, it's just my headphones keep going in and out. I was just thinking about sort of self-mentoring and using writing and reflection, and having, I don't know, I was thinking of reflective journals, and then being able to work with that material, and helping people become much more sort of critically reflective. So you've got the observation of practice, which I guess is the very intensive bit, where you've got the mentor with the mentee, but how you help the mentee sort of really be able to journal or write or record what's going on, and then have a critical conversation around that, which becomes non-judgmental. You know, it's not like marking an assignment, but becomes a much more discursive narrative type of mentoring, if that makes sense. So you're not there present all the time. So it maybe you go from a very intensive to a less intensive process with an individual who you're mentoring as they become much more skilled at self-reflection.
I would say, and I think I'm open to correction from my colleagues, what certainly came out in the big review that Paul Stokes did was we could focus more on the developmental mentoring component of our mentees, and also more on principles of lifelong learning. So, and I think our focus hasn't generally been that. It's been more on making sure that they are ticking the boxes of their own learning. You know, this is the curriculum, this is what we want them to be competent at. Whereas, I mean, it's a critical thing that needs to be increased, and I mean, it's clearly being increased already, but we need to, I think, put a lot more work into that, is creating lifelong learners, creating reflective practice. And I mean, you're sounding British, and I just know the massive elements of British medical student training. I mean, there's just a huge amount of reflective practice. In fact, if I speak to any medical students or people who've recently qualified who I do bump into, they all freak out and say, "Oh, reflect, reflect, reflect." That's all we ever told to do. But still, it's there's no question that there's massive benefit in doing that, and I think that's something we need to increase in. Is just this more developmental and development of a lifelong learner approach in the way we do our mentoring.
And I think, yes, I come from a nursing background in the UK a long time ago. So reflection, yes. But I guess I think it's something that your mentors could possibly start by doing themselves in. So I asked the question about their supervision as a way for them to really to be able to engage in their own practice. And then you've sort of got both mentor and mentee reflecting and role modeling that, because I think you've got to get over that sort of hurdle of vulnerability. People might feel very vulnerable reflecting, or they're not good at it. It's easier to be taught sometimes.
Would anyone, I mean, either MSF people who are involved in the programs, but anyone else like to add to this? Because I think it's an interesting, I mean, it really is an interesting direction that that is definitely core element of education now. Anyone else like to speak of experiences of doing that and where they found it working and not working?
Well, nobody is going to go. I mean, we do know about that, but in different areas, we're trying to promote the use of self-assessment tools. I'm not saying that's really getting to self-reflection, but still, it's probably okay. We're seeding. Let's see where it goes. But
I know we're about to run out of time. Maretta, I'm going to hand the baton to you just for a moment. I see you've made a comment that inevitably will come up, and that is about just what we keep calling the silver linings of COVID amongst the many dark clouds. So would you like to just speak a little bit to that? Because I think it really is interesting.
Yes, like I shared in the group, I recently did an interim position in Brussels as the head of the learning and development. And what I realized there was we were running very fast to digitalize our learning offer. And in that process, also having a lot of reflections on the 70-20-10 and how that was going to look in the future. And I think clinical mentoring is a very essential part of it, also being a medical organization, to try to, when the COVID is over, and we need to look at our learning offer even before to see how we should take the best lessons learned from what we've been doing in the last 18 months and apply that and see how we can change the way that people learn, basically. And I think in MSF, what we've been focusing on for way too many years, it has primarily been the international staff going to the field to work in our field projects, which is basically only 10% of our global workforce. So for the whole rest of it, we need to see how we can adapt our learning solutions so they are much, much closer to the learner in the field and close to our social mission and our operations. And like I said, I think clinical mentoring is a very big part of it, like coaching and mentoring is as well. Communities of practice and peer sharing and all of these things should happen in the workplace. And in MSF, I see that the thoughts are going on, and I think it also creates a momentum for the clinical mentoring, that this is actually the time where we need to strengthen it and build it up, because the future is, in my opinion, learning much closer to the learner in the workplace.
Thanks, Maretta.
You're welcome.
Ian, there's one more hands up from Alan.
Ah, Alan. Nice. I was about to say I'd love to hear from you. So it's wonderful you stepped in. Nice to see you again. I think you're on mute. You're mute, Alan.
Sorry. I was saying nice to meet you, to see you again, Jan, and I can't agree more with what Maretta just said. Just kind of a different question and maybe an idea, Jan, for a new study research. I think many studies have demonstrated how mentoring program can impact positively on DEI programs, meaning diversity, equity, and inclusion in improving diversity, in mitigating or reducing some discrimination in the workplace. I just I'm aware clinical mentoring is different than the mentoring that is referred in this research, but I'm actually curious if clinical mentoring could also have similar impact. So maybe it's more of a question for Terence or whoever wants to as an opinion on that. I just think it can be really interesting to look at that.
So Terence, you've got a direct question. Over to you.
Sorry, Alan. Unfortunately, I only had the end when you were mentioning my name. I think maybe there was a problem with internet on my side. I'm really sorry about that.
Sorry, it's okay. I was saying in the beginning, many studies have demonstrated how mentoring program can impact positively issues related to diversity, equity, and inclusion in the workplace. While I acknowledge clinical mentoring is somehow different, there are also similarities, and I'm curious to see if you have noticed in Embu, for example, or in other projects, or if we could in the future look at how clinical mentoring is also maybe, I don't know, also impacting in a positive way diversity, inclusion and equity in the workplace.
Okay. Yeah, that's a very great question, Alan. And I think we might have the opportunity to do this. But what has been happening in the past is, for example, we have had what we call experts or people who have more technical skills to come into the field. But the problem is that the traditional way of learning was just they would come just for a classroom training, and then afterwards they would leave. But as I mentioned in the beginning, clinical mentoring, it's really hands-on. So it needs someone to be there for at least maybe, depending on how long the module is, 4 weeks to 12 weeks, or sometimes we might have several modules. But if really people are willing to be there for that long time, I don't think it will be a problem. It will actually probably work in terms of diversification and also including other people. So yeah, I think we have an opportunity there.
Thank you.
Yeah, I'm just very grateful for this session. It was very interesting to connect with all of you. I had some very nice discussions, and very cool to hear the opinions and the views of the people around the table here. So thank you for that. Thank you for sharing, and thanks Terence, Ian, and Sylvie for helping us out here.
Yeah, I mean, I would just echo that as well and just say thank you. It's been fantastic to just be in this forum and to hear opinions, ideas, thoughts, and the questions as well, which we'll definitely take further. Terence, sorry.
Yes, thank you very much for actually giving us the opportunity to talk about our clinical mentoring program. And thank you so much for all your questions, your suggestions. I think that's really even thought-provoking to us. That will also help us in future and how we can improve our program. So thank you so much for your time, for being with us today.
They've said it all. Thanks a lot.
Well, thank you. Can I add thanks as well on behalf of EMCC Global as well. You've led such an amazing discussion, and thank you everybody for your input into the dialogue as well. I think that the stories that you've shared and the perspectives you've shared shows how we're just moving in ever complex times. I think the experience of MSF that naturally work in a very, very complex environment, and then the addition of COVID and the addition of all the things that we've had over the past few months as well has had such an area of resonance for everybody. So thank you, everybody.